ভালভিউলার হার্ট ডিজিজের লাস্ট স্টেশনে এসে পৌঁছেছি। শুরু করা হয়েছিল রিউম্যাটিক ফিভার, তারপর শুরু করা হয়েছিল রিউম্যাটিক হার্ট ডিজিজ। সিকোয়েন্স মেনটেন করে আমরা গেছিলাম মাইট্রাল স্টেনোসিস, মাইট্রাল রিগারজিটেশন। আজকের আলোচনা হবে অ্যাওর্টিক ভালভ ডিজিজ। সেক্ষেত্রে মাথায় রাখতে হবে অ্যাওর্টিক ভালভ অ্যানাটমি, second, the pathophysiologic basis of aortic stenosis, then the pathophysiologic basis of aortic regurgitation. So components of today's discussion is second, aortic valve function, third, disruption of aortic valve function in the form of stenosis and regurgitation. Stenosis is virtually a process of pressure overload from the hemodynamic point of view, and regurgitation is virtually a volume overload in the process of hemodynamics. Now coming to the anatomy of aortic valve and its components. তোমরা অলরেডি জানো যে অ্যানাটমি বলতে এবং তার সাব কম্পোনেন্ট বলতে ফার্স্ট হচ্ছে অ্যাওর্টিক ভালভ ইজ ট্রাইলিফলেট ইন কন্ট্রাস্ট টু মাইট্রাল ভালভ দ্যাট ইজ bicuspid or bileaflet. Second, the components are more or less similar, that is the annulus and the root, then commissures, then valve leaflets, then chordae tendineae, then papillary muscles, and ultimately a subjacent myocardium. So abnormality of any component may produce valvular lesions like aortic stenosis or aortic regurgitation, and a combination of these two. Anatomy of aortic valve already described. Aortic valve is the crucial point at the junction of the LV outlet and the initiation of the ascending aorta. The crucial point in the sense a valve is responsible for ejection of blood to the other parts of the body for maintenance of the organ functions efficient. Normal valve function of aortic valve, especially the ejection of blood into the systemic circulation for supply or delivery of oxygen and other essential nutrients to the metabolizing tissues. Second, the prevention of reflux or retrograde flow of blood into the left ventricle. Valve undergoes opening and closure in response to pressure differences between the left ventricle and the aorta, that is the pressure gradient. On the basis of pressure gradient, we can assess the severity of the aortic valve stenosis. Aortic stenosis means an obstruction to the blood flow from the left ventricle to the aorta. An obstruction is a result of stenosis, that means narrowing of the valve leaflets or valve orifice area. Anatomically, it may be valvular, supravalvular, or subvalvular. Today's discussion is mainly concerned with the valvular deformity of the aortic valve. So, valvular aortic stenosis is the point of discussion, but the supravalvular and subvalvular aortic stenosis should also be kept in mind. Supravalvular obstruction, a congenital form of fibromuscular or fibromembranous diaphragm producing obstruction. Second, subvalvular aortic stenosis, again it produced by fibromuscular or membranous obstruction to the LV outflow. And third, the hypertrophic cardiomyopathy. This is a different entity that should be discussed in the class of cardiomyopathy and myocarditis discussion. Now, this is the aorta and this is the supravalvular narrowing. This is the aortic valve. This is the aortic valve. This is the valvular stenosis or atresia, and this is the subvalvular stenosis. So, the discussion should be confined and focused on valvular stenosis, keeping in mind the supravalvular stenosis as well as subvalvular stenosis. Now, etiologic point of view, aortic stenosis is mainly the most common valvular disease in the adult population of the valvular heart disease. That means most common valvular heart disease in the adult population with chronic valvular disease, especially over the age of 50, and there is a male preponderance. The pathogenesis or etiology is on the basis of number 1, calcific degeneration, number 2, the tri-leaflet deterioration, and number 3, the congenital, that is the bicuspid or unicuspid aortic valve. Then comes the rheumatic inflammation, and lastly mediastinal irradiation. Now coming to the point of etiologic basis, 1, congenital in the form of unicuspid or bicuspid aortic valve. Second, the fibro-calcific degeneration, or more precisely progressive deterioration with calcification and fibrosis. Third, rheumatic inflammation, and fourth, mediastinal irradiation. Now coming to the point of the fibro-calcific degeneration. Calcific aortic valve stenosis is not a static process. It is a dynamic process having in common certain features of vascular atherosclerosis that may include endothelial dysfunction, meta-inflammation with cytokine release, and the lipid accumulation with resultant fibrosis and subsequent development of calcification. So, fibro-calcific aortic stenosis is a dynamic process associated with the aging process coupled with the features of vascular atherosclerosis, including endothelial dysfunction, lipid accumulation, and the meta-inflammation with cytokine release with resultant fibrosis, calcification, and narrowing of the aortic valve orifice area. Second pathology is bicuspid aortic valve, most common congenital heart disease in the adult population. Most common congenital heart disease in the adult population. It has a genetic basis with autosomal dominant inheritance with incomplete penetrance. Male-female ratio is 2:1. Usual age group is 10 to 20 years. It may be associated with aortic stenosis as well as aortic regurgitation. And aortic stenosis or bicuspid aortic valve produces some sorts of hemodynamic alteration, and in response to that alteration, there is additional injury leading to again scarring, fibrosis, and narrowing of the aortic valve. Third process is rheumatic inflammation. Again, the process of scarring, fibrosis, and calcification are responsible for rheumatic aortic valve stenosis. And lastly, irradiation. As for example, mediastinal irradiation also produces scarring, fibrosis, and with passage of time, calcification, producing aortic stenosis. The risk factors for aortic stenosis, these are hypertension, chronic kidney disease, diabetes mellitus, dyslipidemia, especially the elevation of the LDL cholesterol and elevation of the lipoprotein A level. The risk factor hypertension, chronic kidney disease, diabetes mellitus, dyslipidemia. These risk factors are responsible for the terminology aortic valve stenosis at risk or high risk for aortic valve stenosis. Now the age group, congenital, common age group 0 to 30 years, bicuspid 30 to 50 years, rheumatic 30 to 60 years, and degenerative more than 60 years. bicuspid aortic valve সম্পর্কে আগে বলা হয়েছে এটা একটা ইয়াঙ্গার এজ গ্রুপ বা ইয়াং চিলড্রেনের ক্ষেত্রে বেশি দেখা যায়, মানে it is a congenital heart disease, but the mainly asymptomatic in that particular age group is usually symptomatic after the age of 30, but definitely it occurs on routine, it detected on routine checkup in the age group of 10 to 15 years, but manifestations occur in the age group of 30 to 50 years. Congenital 0 to 30 years, bicuspid 30 to 50 years, rheumatic 30 to 60 years, and the degenerative more than 60 years. Now progression of the fibro-calcific aortic stenosis or degenerative calcification of the aortic valve. Degenerative calcification, that means there are two components, one degeneration, second is the calcification. First point, the at risk, that means genetic basis and the risk factors already described, including dyslipidemia, aging process, chronic kidney disease, diabetes mellitus, hypertension, smoking, physical inactivity, etc. Then the aortic sclerosis and aortic stenosis. Aortic sclerosis is the initiating point, that is the disease initiation. Disease initiation এর পরের step progression or progressive disease, and ultimately coupled with the valvular obstruction. This is the stage or temporal profile of the genesis of degenerative calcified aortic stenosis. At risk, then disease initiation, then disease progression, then the valvular obstruction. Rheumatic aortic stenosis, there is initial commissural fusion, then the abnormal hemodynamics, then the abnormal hemodynamic insult to the valve leaflets as well as other components of the valve, then the production of the scarring fibrosis with the passage of time calcification. And calcific aortic stenosis already discussed previously, such as at risk, disease initiation, disease progression, and valvular obstruction. Pathophysiology. Valvular aortic stenosis produces the pressure overload. Aortic stenosis, pressure overload, induction of the mechanical transducers, then induction of the extracellular and intracellular signals, then ventricular remodeling, parallel sarcomeres and the series sarcomeres. Parallel sarcomeres goes to the concentric hypertrophy and series sarcomeres goes to the eccentric hypertrophy. Aortic stenosis, pressure overload, increase in systolic wall stress, induction of the mechanical transducers, then induction or amplification of the extracellular and intracellular signals, then ventricular remodeling, parallel sarcomeres, concentric hypertrophy, and the series sarcomeres, that is the eccentric hypertrophy. That means hypertrophy with chamber dilatation. Concentric hypertrophy means hypertrophy without chamber dilatation. Rather, it increases the chamber and reduces the compliance. So, what is the ultimate anatomical and hemodynamic effect? Anatomical effect is the left ventricular hypertrophy and the reduction in the left ventricular myocardial compliance. And the hemodynamic impact is elevation of the left ventricular end diastolic pressure. This is the anatomic and hemodynamic impact of aortic stenosis. Clinical presentation is sad, really very sad. That means syncopal attacks, angina pectoris, and dyspnea, especially dyspnea on exertion. The classical triad or classical clinical features are really sad. That means S for syncopal attacks, A for angina pectoris, D for dyspnea on exertion. In addition to that, there may be evidence of arrhythmias, evidence of complications in the form of congestive heart failure, or on a rare instances, evidence of sudden cardiac death. Classic symptoms, that is SAD, syncope, angina pectoris, and the dyspnea on exertion. On exam, first, usually pulse is, the radial pulse is regular and low volume. Then the BP, there is truncation of the systolic BP with low pulse pressure. Truncated systolic BP with low pulse pressure with the exception of coexistence of hypertension in the elderly subjects. Then, the jugular venous pressure, there may be prominence of the A wave due to the reduced compliance of the right ventricular myocardium or distensibility right ventricular due to the encroachment of the hypertrophied interventricular septum into the right ventricle. So there may be prominence of the A wave. Then the carotids. There may be a thrill or anacrotic shudder on the carotid. or in the suprasternal notch. তো কোন দিকে দেখা যাবে carotid shudder or thrill, ডান দিকে না বাঁ দিকে? Left. Carotid thrill is most in the left carotid rather than in the right carotid. Then character of the pulse. Here the character of the pulse is best assessed at the carotids, not at the radials. At the carotid, there may be two peaks. That is the ভুল বললাম, টু পিক্সের ক্ষেত্রে হবে না, ছেড়ে দিচ্ছি। Carotid, the pulse is the delayed slow upstroke. It's a slow with a delayed upstroke known as Pulsus, Parvus, et Tardus. So, character is best appreciated in the carotids. The pulse is slow with a delayed peak known as Pulsus, Parvus, et Tardus. In association with aortic regurgitation, there may be pulsus disferience. That means the two systolic peaks that is narrowly separated. Two systolic peaks that is narrowly separated. Usually uncommon in isolated aortic stenosis, but much more common when it presents with the aortic regurgitation. এক্ষেত্রে একটি কথা বলতে ভুলে গেছি যে রিউম্যাটিক ইনফ্লামেশন থেকে যে অ্যাওরটিক ভালভুলার স্টেনোসিস অ্যারাইজ করে, সেক্ষেত্রে অলমোস্ট অলওয়েজ মাইট্রাল ভালভ ডিজিজ অথবা অ্যাওরটিক রিগার্জিটেশন অ্যাসোসিয়েটেড থাকে। So aortic stenosis resulting from rheumatic inflammation is almost always associated with mitral valve disease or aortic regurgitation. Then the precordium, apex bit, it usually at its normal position due to concentric hypertrophy, but may be displaced downwards and outwards in the presence of dilatation in the later stage. Character, forceful, well sustained. What is well sustained? That means the duration of the impact with the fingertips is more than half of a normal systole. Then there may be double apical impulse due to the presence of S4 or rapid atrial contraction. Then the diameter is 2.5 centimeter or more. The apex, number one, at its normal position or displaced outward and inferiorly. Character, forceful, well sustained. Diameter 2.5 centimeter or more. Then presence of a systolic thrill, especially at the right base of the heart, that means right second intercostal space, may also be heard in the left intercostal space, that is the left second intercostal space. So a systolic thrill. Again, a systolic thrill at the level of the suprasternal notch, and at the apex there may be palpable S4. So findings on precordial exam, there is S1 usually normal or reduced in intensity in case of calcification or valve immobility. S2 is usually single or split, that is the paradoxical split, because due to delayed emptying of the left ventricle, aortic valve closure may be delayed. So A2 and P2 is mixed or synchronous producing a single second sound, or A2 may undergoes closure after P2, producing paradoxical or reverse split. There is a presence of S4. There is presence of the ejection click, early ejection click, based hard at the right second intercostal space. These are the auscultatory findings. Now, the main thing is the murmur. The murmur of aortic stenosis is the harsh or rough, rasping quality murmur based hard at the right second intercostal space or around the right heart border. Right second intercostal space, a high-pitched, harsh, rough, or rasping quality systolic murmur with radiation to the carotids. But on occasion it may radiate to the apex of the heart, that is the Galaverdin effect or impact. These are all the basic summaries of the aortic valve stenosis findings on auscultation. Now the murmur, this is the crescendo, decrescendo in time, early systolic or mid systolic, and the later the peak of the murmur is the reflection of the severity. The time is virtually a surrogate for the gravity of obstruction. Now coming to the point of the murmur. Ejection systolic murmur, a diamond-shaped murmur occurs between S1 and S2. As stenosis severity increases, the timing of the peak intensity shifts from early systole to late systole, reflecting the prolonged time needed to eject blood through a narrow orifice. The later the peak of the systolic murmur, the more severe the stenosis. In the cardiology, time truly is a surrogate for gravity of obstruction. Lab exam, investigations ECG, chest X-ray, cardiac catheterization, and coronary angiography. ECG shows left ventricular hypertrophy with the systolic strain, that means ST segment depression with convexity upwards. The apex or nadir of the T wave is blunt. So ST segment depression with convexity upwards and is asymmetrical with a blunted apex or nadir in association with LVH. This is the classical features of the aortic stenosis in the EKG. Second, CXR, usually cardiac salute is normal because of concentric hypertrophy, but with the passage of time and progression of the disease, the development of dilatation may produce cardiomegaly or increase in the cardiothoracic ratio. Then the cardiac catheterization. Both right and left heart catheterization are indicated, not always, but in certain situations. Number one, multivalvular disease, যেখানে কোন valvular ডিজিজের ইম্প্যাক্ট কতটি সেটুকু অ্যাসেস করার জন্য। So multivalvular disease in whom the role played by each valvular deformity. Second, young asymptomatic with non-calcification bicuspid aortic valve in an attempt to assess the severity of obstruction. And lastly, obstruction to LV outflow tract, but it's very difficult to determine the site of obstruction. That means whether supravalvular, valvular or subvalvular. In that case, the cardiac catheterization is needed. Number one, valvular heart disease. Number two, young asymptomatic with non-calcific bicuspid aortic valve. And number three, to determine precisely the level of LV outflow tract obstruction. Coronary angiography is indicated preoperatively, that means before the surgical intervention of the aortic stenosis, as well as the presence of the coronary arteriosclerosis and the contribution of the angina pectoris by means of the valvular pathology or by means of the coronary atherosclerotic pathology, and which one is much more important, that is essential for the therapeutic implications. Treatment, medical treatment. First, severe AS, that means aortic valve orifice area less than 1 square centimeter. Normal aortic valve orifice area is 2 to 4 square centimeter. Normal aortic valve 2 to 4, mitral 4 to 6. পরে আসছি কোনটা সিভিয়ার, তারপরে আসবো স্টেজিং। Now medical treatment, severe MS, that is the valve orifice area less than 1 square centimeter. Strenuous physical activity and competitive sports should be avoided even in the absence of symptoms. So severe stenosis, avoidance of the strenuous activity. Second, to avoid dehydration and hypovolemia in an attempt to further reduction, in an attempt to prevent the further reduction in the cardiac output. And third, medications for hypertension or coronary arterial disease may be indicated, especially beta blocker or ACEI, but HMG coenzyme A reductase inhibitor as well as inhibitors of the RAS, that is the renin-angiotensin-aldosterone system, is not classically indicated in the setting of aortic stenosis. Rather, it is indicated for primary or secondary prevention of atherosclerotic cardiovascular disease. And lastly, endocardial prophylaxis, only in the situation in which a history of previous thromboembolic complications or history of endocarditis occurs. So medical treatment, avoidance of the strenuous physical activity, avoidance of the dehydration, hypovolemia. Medications should be meticulously used for coronary atherosclerotic disease like beta blockers and ACEI. Nitroglycerin may be used in case of angina pectoris, especially implicated by the CAD. Then the HMG coenzyme A reductase inhibitors or statin, as well as RAS activity in case of secondary or primary prophylaxis of the arteriosclerotic cardiovascular disease, and endocardial prophylaxis is restricted to the history of previous endocarditis as well as the thromboembolic complications from the endocardial vegetations. Operation is indicated. First, severe aortic stenosis was symptomatic. severe aortic stenosis who are symptomatic. Second, with LV dysfunction, that means LVEF less than 50%. Third, aortic stenosis due to bicuspid aortic valve. Fourth, an aneurysmal root or ascending aorta. Aneurysmal root or ascending aorta maximal dimension or diameter is 5.5 centimeter or more. But operation is indicated at a smaller aortic diameter such as 4.5 to 5.0 centimeter in which a family history of aneurysmal catastrophe or who exhibit rapid progression of the aneurysm, that means 0.5 centimeter per year. What are the process of the surgical intervention? First, percutaneous aortic balloon valvuloplasty. Percutaneous aortic balloon valvuloplasty. Second, transcatheter aortic valve implantation. Transcatheter aortic valve implantation, that is done through the femoral approach. And lastly, surgical aortic valve replacement. So the types of surgery: 1. Percutaneous aortic balloon valvuloplasty. Second, transcatheter aortic valve transcatheter aortic valve implantation. Third, surgical aortic valve replacement. Now, severity from the hemodynamic or echocardiographic criteria. Mild, that means mean gradient, that is the less than 25 millimeter of mercury, valve orifice area more than 1.5. Moderate, 25 to 40, valve orifice area 1 to 1.5. Severe, more than 40, and aortic valve area less than 1 square centimeter. And the critical, that is the transvalvular pressure gradient exceeding 80 millimeter of mercury, and the valve orifice area is less than 0.7. Now the stage. Aortic stenosis এর স্টেজগুলো একই রকম। ফার্স্ট বলা হয়েছিল অ্যাট রিস্ক স্টেজ, অ্যাট রিস্ক, সেখান থেকে শুরু করে স্টেজ এ, স্টেজ বি, স্টেজ সি, সি এর সাব ক্যাটাগরি আছে C1, C2, স্টেজ ডি, ডির সাব ক্যাটাগরি আছে D1, D2, D3। এই যে সাব ক্যাটাগরি এবং ক্লাসিফিকেশন or staging of aortic stenosis is on the basis of valve anatomy, valve hemodynamics, hemodynamic consequences, and the presence or absence of symptoms. Now, what is the valve dynamics? There is risk. Stage A, at risk for disease. Risk already mentioned, like hypertension, dyslipidemia, smoking, etc. Stage B, this is the progressive or disease. Stage C, that is the asymptomatic. Stage D, this is the severe and symptomatic. Now clarification. Stage B, mild to moderate obstruction, that is the progressive aortic stenosis. Stage C, asymptomatic severe aortic stenosis, C1 with normal ejection fraction and C2 with reduced ejection fraction. D, severe aortic stenosis, that is symptomatic. This is the D, symptomatic. Severe high gradient aortic stenosis, D1. Second, symptomatic. severe low flow, low gradient aortic stenosis with reduced ejection fraction. And D3, it is the low flow, low gradient aortic stenosis but with preserved ejection fraction. These are the stage. Stage A at risk, stage B progressive disease, stage C, this is the severe, and stage D symptomatic severe. মনে রাখার সুবিধার জন্য এখানে চলে আসছি স্টেজ এ অ্যাট রিস্ক ফর ডিজিজ, স্টেজ বি প্রোগ্রেসিভ, স্টেজ সি সিভিয়ার ডিজিজ, স্টেজ ডি সিভিয়ার সিমটোম্যাটিক ডিজিজ। এটা অলরেডি বলে দেওয়া হয়েছে। Now the valve surgery or surgical management of valve is dependent on number one, severity on the basis of staging. Second, presence or absence of the symptoms. Third, the valve pliability. Fourth, the presence or absence of the comorbidities, especially coronary arterial disease. These all parameters constitute the type of surgery for aortic stenosis. That's all. Now, prognosis, onset of symptoms and the survival. Symptoms, that is the angina, median survival 5 years. Syncopal attacks 3 years. Dyspnea 2 years. And the congestive heart failure 1.5 years. এখানে একটু ভুল আছে। Now, aortic regurgitation. Again, that should be discussed. Anatomy, etiology, pathophysiology, epidemiology, history, physical exam, natural history, differential diagnosis, investigations, severity, medical management, surgical management, and long-term monitoring, and lastly the prognosis. Aortic regurgitation is a condition due to inadequate closure of the valve leaflets, leading to leakage of blood from the aorta to the left ventricle, producing a volume overload of the left ventricle. It can be induced by damage or dysfunction of the two components of the aortic valve. One, root involvement, number two, valve involvement. So from etiologic point of view, aortic regurgitation is due to pathological process involving the roots or pathological process involving the valve leaflets itself. The prevalence is varied with age and disease severity. More than trace air was unusual before age 50 and then increases progressively. For mild air, prevalence rate is 7 to 12% in case of male, but the comparable values in women is the 2 to 14%. That's all regarding epidemiology. Now, causes of aortic regurgitation. আগেই বলা হয়েছিল দুটো কম্পোনেন্ট, root abnormalities or leaflet abnormalities. Leaflet abnormalities এর মধ্যে থাকছে rheumatic fever, endocarditis, trauma, again bicuspid aortic valve, rheumatoid arthritis, ankylosing spondylitis, and the acromegaly. Aortic ascending aorta, systemic hypertension, most common, aortitis, reactive arthritis, ankylosing spondylitis, dissecting aneurysm, Marfan syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta, and inflammatory bowel disease. Pathophysiology, again, aortic regurgitation, the diastolic wall stress, then the induction of the mechanoreceptors or mechanical transducers, then the amplification of the extra and intracellular signals, then the ventricular remodeling, এক্ষেত্রে appear করে first eccentric hypertrophy, that is the series sarcomeres, or on occasion concentric hypertrophy through involvement of the parallel sarcomeres. Now symptoms. Symptoms of dyspnea, orthopnea, paroxysmal nocturnal dyspnea, chest pain, nocturnal angina or exertional angina. With extreme reduction in diastolic pressure, usually angina is present. Cause of angina, the dilatation and hypertrophy of the left ventricle, enhancement of the myocardial oxygen demand, and compression of the epicardial coronary arteries. Peripheral signs. First, the capillary pulsation or Quinke's pulse. That means alternate flushing and peeling of the skin at the base of the nail on slight compression. This is the Quinke sign. Then the Corrigan's or water hammer pulse. That means sharp rise followed by sharp fall without any summit, water hammer pulse or Corrigan's pulse. Then the wide pulse pressure due to relative systemic hypertension or systolic hypertension and diastolic hypotension. This is the pulse pressure, wide pulse pressure. Carotids bispherines pulse, যেটা বলার চেষ্টা করছি, in case of severe aortic regurgitation or aortic regurgitation plus aortic stenosis, there is pulsus bispherines. That means two narrowly separated systolic peaks at the carotids. D Masset's sign, that is the systolic head nodding or bobbing with each systole, and Muller's sign, systolic pulsation of the uvula. Then the Direzio's sign, that means a to and fro murmur over the femoral artery by slight compression with the stethoscope. To and fro murmur, that means both systolic and diastolic. And then the Traube sign, it is the booming sound at the femoral artery, booming sound at the femoral artery. That is the Traube sign, also known as pistol shot sound. And then the heel sign, that means lower extremity BP is higher than the upper extremity BP. If more than 2 millimeter, mild MR, more than 40 millimeter, moderate MR, and more than 60 millimeter, it is the severe MR. Now the apex. Apex which is displaced, number 1. Forceful, number 2. Diameter exceeding 2.5 centimeter or more, number 3. Yield sustained, number 4. Yield sustained means duration of impact of the apex beat with the fingertips is less than half of a normal systole. Hyperdynamic associated with the presence of the S3 as well as medial retraction. And third, the Austin Flint murmur, that means a mid-diastolic rumbling murmur due to the displacement of the anterior mitral valve leaflet. It is the mid-diastolic rumbling murmur at the apex even in absence of the mitral stenosis known as Austin Flint murmur. Now the aortic diastolic murmur, a hoarse, blowing, diastolic decrescendo murmur best heard at the left heart border. But in case of root dilatation, the murmur is best heard along the right heart border, along the right sternal border. So in case of leaflet pathology, the murmur radiation is along the left sternal border. In case of aortic root dilatation, the radiation may be along the left sternal border. This is the murmur of aortic regurgitation. And a third murmur, that is the murmur of functional aortic regurgitation, a murmur at the right second intercostal space with radiation to the carotids even in the absence of aortic stenosis. This is ejection systolic murmur. So murmur type is tinte. Number one, murmur of aortic regurgitation. Number two, functional murmur of mitral valve disease like Austin Flint murmur. And number three, ejection systolic murmur of the functional aortic stenosis. And added sound are S1 is usually normal, S2 is variable according to the status and severity of the aortic regurgitation. There may be presence of S3 and on occasion S4 due to the stiffness and the development of concentric hypertrophy. And an additional finding is ejection click. ইজেকশন ক্লিক নিয়ে পরে কথা বলা যাবে। ইজেকশন ক্লিককে আমরা সিস্টোলিক ইজেকশন ক্লিক, নন সিস্টোলিক ক্লিক এভাবে ভাগ করা হয়। ভাস্কুলার ইজেকশন ক্লিক, ভালভুলার ইজেকশন ক্লিক ডিটেলসে পরে আসবো। এক্ষেত্রে যেটা পাচ্ছি সেটা হচ্ছে যে ভাস্কুলার ইজেকশন ক্লিক ইজ ভাস্কুলার সিস্টোলিক ইজেকশন ক্লিক। This is the pattern of the diastolic murmur of the aortic regurgitation. Immediately after the second heart sound, a decrescendo type of murmur and ends well before the first heart sound. Severity. Enhancement of the peripheral signs indicates a parameter for severity. Dilatation of the LV also indication of reflection of the severity. Presence of S3, Austin Flint, and radiological cardiomegaly. All are features for the severity or the clinical parameters for severity of the aortic regurgitation. So in summary, severity of the aortic regurgitation, peripheral clinical signs, LV enlargement or dilatation, auscultatory findings, such as S3 and Austin Flint murmur and radiological murmur or radiological markers such as cardiomegaly. Peripheral clinical signs, LV enlargement or dilatation, auscultatory findings, S3 and or Austin Flint murmur, radiological markers, that is the evidence of the cardiomegaly. Again, the stage A, B, C, D, A at risk, B progressive, C asymptomatic severe, D symptomatic severe. আবার কি valve anatomy, morphology, valve hemodynamics, hemodynamic consequences and symptoms. Management is dependent on the several factors. One, stage. Number two, symptoms. Number three, LV dysfunction. Number four, vena contracta. Number five, regurgitant volume. Number six, regurgitant fraction. Number seven, effective regurgitant orifice area. All these should be assembled to assess the need for valve surgery, especially aortic valve replacement. এবার বলি পরীক্ষায় কিভাবে কোশ্চেন আসতে পারে। সাধারণত এইভাবে কোশ্চেনগুলো সেট করা হয় ভালভুলার হার্ট ডিজিজ থেকে। আমি একটু পড়ে শোনাচ্ছি। A 53 years old gentleman presented with shortness of breath and exertion for last 2 years, increasing in intensity for last 3 months. On exam, he is dyspneic, pulse 128 per minute, irregular, BP 100 by 30 millimeter of mercury, respiration rate 32 per minute, diastolic thrill in apex, mid diastolic murmur in the apical area, early diastolic murmur in the left lower sternal area, and systolic murmur in the aortic area. ECG atrial fibrillation, CXR peer view, cardiomegaly, আর কিছু বলা থাকবে না। এই পর্যন্ত থাকলো। এইবার বলা থাকবে হোয়াট ইজ দ্য পসিবিলিটি, how would you approach for the diagnosis, and what is your outlines of management. লেখাতে ক্লু কী কী দেওয়া থাকছে আমি ছোট্ট করে বলে দিচ্ছি। প্রথম কথা হচ্ছে জেন্টেলম্যান, তার মানে অ্যাওরটিক ভালভ ডিজিজের কথা আমি ভাবতে পারি। ফিমেলের ক্ষেত্রে অ্যামাইটাল ভালভের কথা, মেলের ক্ষেত্রে অ্যাওরটিক ভালভের কথা। সেকেন্ড ক্লু কি, শর্টনেস অফ ব্রেথ ফর এক্সারশন ফর লাস্ট 2 years। আমার ক্লাসিক্যাল সায়েন্স অফ ভালভুলার হার্ট ডিজিজ, এইটাই পরীক্ষাতে আসবে, আগে যা বললাম কিছু আসবে না। কোশ্চেনগুলো এইভাবেই সেট করা হয়। সেক্ষেত্রে সেকেন্ড ক্লু হচ্ছে ডিসপনিয়া, a classical parameter or classical symptom of the cardiovascular disorders. So we are going to deal a case of cardiovascular disorder in a 50-year-old male subject. But কি পাচ্ছি, dyspnea পেয়েছি, pulse, tachycardia, that may be a features of failure, that may be a features of arrhythmia. Second কি পাচ্ছি, irregular, that means presence of the premature contraction, either supraventricular or ventricular, or presence of the atrial flutter with variable block or atrial fibrillation. BP, that is the low, 100 by 30 millimeter of mercury. Respiration rate is high. Dyspnea with respiration rate exceeding 32. Definitely we are going to deal a case of failure even in the the presence of pulmonary edema. And diastolic thrill at the apex, diastolic thrill at the apex পরিষ্কার করে বলা আছে যে পেশেন্টের যদি aortic regurgitation থাকে তাহলে diastolic thrill পেতে পারি even in absence of the mitral valve disease. Third কি, early diastolic murmur in left lower sternal area and systolic murmur in aortic area. পরিষ্কার করে এখানে aortic rejection, systolic এবং লেফট স্টার্নাল বর্ডার এবং এপেক্সে aortic regurgitation এর মারমারের কথা বলা আছে। ECG atrial fibrillation, cardiomegaly, much more common in aortic regurgitation, contrasted to aortic stenosis. That's enough. Possibly it is a case of aortic regurgitation complicated by arrhythmias and the development of the heart failure, especially cardiogenic pulmonary edema. এবার অ্যাপ্রোচ কী হবে, হিস্ট্রি, ফিজিক্যাল এক্সাম, ইনভেস্টিগেশনস, তারপরে কী হবে ডায়াগনস্টিক ওয়ার্কআপ। এইটা দেখানোর উদ্দেশ্য একটাই, কোশ্চেনগুলো আবার রিপিট করছি, এই পর্যন্ত দেওয়া থাকবে, এই ফাইন্ডিংসটা বলা থাকবে না।